So just briefly, I'm sure we all know what TPORAs are, but there are now 3 in Australia, as we've heard. A lot of this will be going over stuff that's already mentioned, but there's no harm in reinforcing things if you really want to, enhance your expertise. So the 3 drugs, romiplostim, which is subcut injection, usually given weekly, L-trombopag, which is an oral tablet given orally between daily and weekly, and similarly with avatrombopag, an oral tablet given between daily and weekly. And no presentation has not included that extremely sophisticated diagram of what they do. You don't really need to pay any attention to that if you don't want to. But I'll just say briefly that avatrombopag and L-trombopag sort of act at the same point in the receptor, but romiplostim, which is the big hexagonal red thing, it does act at a different place in the receptor. So treatment of ITP, it has changed a bit, and that's good. But first line, generally speaking, steroids and IVIG. As we have briefly touched on in previous talks now, there's considerable interest in adding to first line treatment to prevent people with newly diagnosed ITP progressing to chronic ITP. And I'm really happy that this has happened. This is what we've been, I guess, a lot of research focus has gone into chronic ITP, and there was a big unmet need there because chronic ITP was poorly managed for many years. Now it's a lot better managed, but really I think the holy grail is to stop people with newly diagnosed ITP ever progressing. So that's really, I guess, what a lot of the focus is about now in research. Second line is now TPORAs. So it used to be second line treatment would be things like splenectomy or a whole load of medical treatments that essentially were largely done to try and forestall or prevent the need for splenectomy. So since in Australia, but sadly not New Zealand, since the PBS rules change, we now largely use TPORAs second line. So you still need to have a platelet count of 30 or less with bleeding, or a platelet count of less than 20 without bleeding, but you do not require a splenectomy. You also have to have had treatment with steroids and immunoglobulin, or have a reason not to have further treatment with those, but that's an easy thing to meet. Chi, we already mentioned. The other big change, of course, is that treatment can now continue. You don't need to meet a platelet count number response. You just have to have improved on drugs. And that really that's quite a big thing, because I had a lot of patients who were probably at the worst end of the scale of ITP, who'd actually, on treatment with one of these drugs, actually had quite a big improvement in their bleeding, bruising symptoms, felt a lot better, but didn't make the platelet count that they needed to stay on. Most of those I was able to get drug from the companies, provided on what's called a compassionate access program, but now people can stay on the drugs. So really, TPORAs are now second-line treatment, whereas they used to be much further down the order. And what that really means is a whole load of treatments that we used to use before TPORAs and we now actually use afterwards. And that's not a bad thing, because many of these drugs have more side effects, I guess, than the TPORAs. So things have changed a bit. So I think if you have been treated, if you've been told you've got ITP, you've been treated, you've been put on a TPORA and it's not working, one of the things that we always have to remember is, I think everyone said this, but the diagnosis of ITP is not entirely straightforward. So if you've got a low platelet count, you've been treated with steroids, your platelet count's gone up to 300, you've almost certainly got ITP and nothing else. But if you've never responded to treatment, so if you've had steroids and Intragam, your platelet count's not improved on that, you've gone to another treatment, then it is possible that you don't have ITP. There are other causes of low platelet counts. And it's important to remember that people are not perfect. Doctors are not perfect at making diagnoses. And there's a hospital in Canada, there's a health service hospital in Canada, McMaster, where there's a great deal of expertise in ITP and similar bleeding and clotting disorders, where they had a registry. And, you'd think at a hospital with a leading expertise in this condition, they'd get the diagnosis right all the time. But in fact, over a period of months and years after these people were put on a registry, being diagnosed with ITP, 12% of them were actually found to have something other than ITP. So myelodysplasia was the most common. That's a sort of pre-leukemic disorder that's very uncommon in young people, becomes more common as you get older. Hereditary platelet disorders, things that people were born with but just didn't know because they probably didn't have blood tests before. Enlargement of the spleen or liver disease were the other common causes. The other thing about, if the TPORAs are not working is what does not working mean? Because I've certainly inherited over the years a lot of patients from other hematologists even who've been trying to treat people to get their platelet count into the normal range. So that's around about 150 to 400. And in fact, I've had young men who've been treated with so much steroid that they've developed in their 20s, they've developed crush fractures of the bones in their spine because they've been over-treated with this false goal of a platelet count, which is much higher a target than it actually needs to be. So really what you think about, what is the goal of treatment? So if you're saying, oh, the TPORAs failed, what does failed mean? If it stopped your bleeding, it now doesn't matter what your platelet count was. If it's improved your life, you could just carry on with it. So obviously what the goal of treatment is not a platelet count. I mean, we all feel more comfortable with a higher platelet count than a lower platelet count because then if something goes wrong and it drops down, we've got a bit of margin, if you like. But really, what we're trying to do is stop bleeding. So these two graphs show the risk of bleeding, which goes up in a really exponential fashion as you get older. So there was a question about pediatric ITP when you transition to adult life. So when you stop being a kid and become an adult, your bleeding risk does not change, the day you hit 18. But it does progressively increase as you get older. But as you can see from this graph here on your right, the risk really doesn't go up until you get quite a bit older. So if people are under 40, the bleeding risk is really quite small. So you don't need to suddenly think about treatment when you hit the age of 18. The other thing, of course, is platelet count. And there is a increased risk of severe bleeding in this graph when your platelet count gets below around about 30. But, the risk that is of severe bleeding. So really what we want to do is maintain a safe platelet count and reduce the risk of bleeding, not have a particular platelet count goal. So when we look at the TPORAs, they do have some interactions, but not really with the sort of drugs that GPs prescribe in general. Most of the interactions, that is to say, drugs that will interfere with the TPORAs, are the sort of drugs usually that specialists will prescribe. So obviously, if someone wants to prescribe you another drug for another condition, always, you've got to know what treatments you're on and what interferes with what. But there are very few interactions that, drug interactions that stop these drugs working. There are some interactions which are synergistic, which means if you take two drugs together, these drugs work a lot better. So TPORAs with immunosuppressive treatments can actually really boost treatment, and that's one of the options if they stop working, which I'll come on to. The really important interaction, I guess, with the three drugs is L-trombopag and its scheduling. So if people here have been treated with L-trombopag, you'll know that you can't have it with breakfast, with milk, with breakfast cereal and so on. You're supposed to take it an hour before or 2 hours after. But in fact, even then I find, you probably don't get the best from L-trombopag, even if you stick to that restriction. And in fact, a lot of patients I've had on L-trombopag over the years have sort of set their alarm for 4 o'clock in the morning, taken the tablet and fallen back to sleep again. It's a good drug, but it does have this interaction. It's called divalent cations, so nobody knows what you mean when you say divalent cation. It means things like iron, zinc, calcium, magnesium, things that are in milk, things that breakfast cereal is specifically fortified for. So taking them with breakfast. And one of the things I've always found is now as you know, there are 3 drugs available, but I used to always find when patients have been on L-trombopag for years, they used to decide when they take it. And then what I found about 10 years ago or so is a whole load of patients who've been on L-trombopag progressively got admitted to nursing home. And once you get admitted to nursing home, your freedom is removed. You cannot choose when you take your drugs. A nurse comes around with your drugs with your breakfast. And every patient I had on L-trombopag who got admitted to nursing home platelet count dropped within a couple of weeks because they were being given breakfast with drugs, and the nursing home just could not get it right. So really, I've tended to, it's a good drug when it's given properly, but if it's not, it doesn't work well. So I used to switch patients from L-Trombopag to Romiplastim when they got admitted to nursing home. Now, of course, there's the alternative of Avatrombopag as well. So why else might... just to go back one step. So one of the main reasons L-Trombopag fails is this dietary interaction. And what you tend to find is when you first start someone on a drug, they religiously stick to the instructions, but they've been going fine for a year or two, and they kind of relax, do start taking the drug with breakfast or something else, or a drink of milk, or some well-intentioned person starts them on an iron supplement or something like that. So I found that the most common reason for L-Trombopag failure is this poor absorption business. So being started on a supplement, zinc, iron, magnesium. People take supplements because they think they're doing the right thing, but it can be a problem. So one of the things I always go into, if L-Trombopag stops working, is that specific issue of the scheduling with food and with these zinc, magnesium, iron, copper, etc. Another reason, and this has been touched on before, is reversible marrow fibrosis. So most people taking these drugs long-term will have a steady dose over time. Sometimes even the dose gradually goes down as the underlying disease sort of burns out, which a lot of autoimmune diseases can do in time. But sometimes what we find is people need a progressively higher dose. And then you get up to maximum dose, and then the drug just stops working. And when that happens, the one thing you do have to think about is this reversible marrow fibrosis. It's been analysed more with L-Trombopag and Romiplastim because they've been around a bit longer than Avatrombopag, but it seems to be all the drugs do this. If you drive the marrow very hard, maximal dose for a long time, the megakaryocytes produce chemicals in the marrow that causes the marrow to sort of thicken up, and you get this marrow fibrosis. So you can sometimes see signs of this in the blood, but sometimes you just have to go and do a marrow biopsy and look and see what the marrow looks like. Now, if you do find this, you have to stop the drug. So you stop the drug, you use an alternative treatment for around 3 months, and what you find is this fibrosis, it's a reversible fibrosis, it goes away. But you do need to be off drug for 3 months. And then you can often restart back on the same drug at a much lower dose, and it works again. So that's something to be aware of if these drugs do stop. So that's another reason why being on these drugs, they can work fine for a while and then stop working. So looking at now, if you have been on a drug, what are the options? So, it would be wrong not to, I don't think any of my ITP colleagues in this room really loves the idea of splenectomy. We've all seen too many problems, but it can be a good treatment. So splenectomy has been around since 1912 as the treatment. It really was the only treatment for ITP for almost 50 years until steroids started being used. It was first done in Vienna in 1912. The man with the glasses and the moustache and beard is Professor Schlöfer. He was a professor of surgery at this hospital in Vienna. That photo was possibly taken about the same time the operation happened. The other photo is a guy called Cas Nelson, and that photo was taken in 1948, so a long time afterwards. Now, Cas Nelson was a medical student in Vienna, and he, as a medical student, convinced his professor of surgery that a splenectomy might be a good treatment for ITP. And to the credit of Schlöfer, he listened and actually did the splenectomy. If a medical student came up to me and started telling me what I should do for patients, I'm not sure I would be quite as accommodating, but it just goes to show sometimes people can have good ideas when they even don't have much training experience. So splenectomy, the good. 90% of people have an immediate response to splenectomy. However, a few people who get that immediate response will then lose response, but still long-term, 2/3 of patients who have a splenectomy will respond. The other thing you tend to find with splenectomy is once the spleen is gone, then you'll find people who've had treatment with various drugs, if you retreat them with those drugs, may then respond again to those previously used drugs. So that's the good with splenectomy. So I've done very few splenectomies in the last 5 years. In fact, the only splenectomies I've done have been in professional athletes. So I've had a couple of rugby league players, a couple of rugby union players, in fact, that have played for Australia. And they were absolutely adamant they didn't want to be on any long-term drug. I pointed out to them I didn't think there was going to be any issue with drug testing, but the idea of being on any long-term drug just really was too much for them, and they wanted a surgical treatment. And in fact, they did, recovered, and two subsequently went on to continue playing rugby union for Australia and won rugby league. So that was a good story. The bad with splenectomy is you get these clots in the blood vessels, the veins around the spleen. So about 30% of people, if you do a splenectomy for ITP, will get a symptomatic clot in their belly. In other words, they get pain, they get bloating, they get some reason why you check for a clot. But if you actually scan people who've had a splenectomy for ITP, so you go looking for a clot, 70% of patients who've had a splenectomy for ITP will get a clot in one of those abdominal veins. Also, following splenectomy, you do get a long-term increased risk of serious bloodstream infections. And for that reason, there's a recommended vaccination schedule, and it's recommended that you take an antibiotic either to prevent infection or you have antibiotics on hand to take if you become unwell with a fever. Spleen Australia is a site where anyone who's undergone a splenectomy should be registered, so they get reminders about vaccination and a bit of education around what the right things to do if you've had a splenectomy are. There's also a long-term increased risk of blood clots, and that's probably because you're not addressing the underlying cause of ITP, you're just allowing the patient platelets to survive because the spleen isn't destroying them. So you've got these platelets circulating around that have an increased propensity to cause blood clots. And there is, again, it's probably less clear, but there's a possible long-term mild increase in the risk of blood cancers following splenectomy as well. So there are certainly some downsides of splenectomy. Other alternative, if you've been on TPORA, it stopped working, is rituximab. So this is something I always used to use before splenectomy. So rituximab is an antibody to B cells. We've had the lessons about B cells. So 60% with people with ITP will have a response to rituximab, an initial response. Around 25% will have a long-term response, which may, in some people, amount to a cure. Generally given as a weekly infusion for 4 weeks. Average time to response from the first dose is around 5.5 weeks. Serious side effects are very uncommon. So I've treated 143 patients with rituximab, some of them more than once. And what certainly I've found, really agrees with what's more broadly understood, which is that people who you'd expect to respond best are younger, have a lower platelet count, shorter duration of ITP, female. And the thing that I've found is a broader underlying autoimmune profile. That means to say people might have anti-thyroid antibodies or lupus-type antibodies. They don't necessarily need to have immune thyroid disease or lupus, but if they've got those antibodies detectable, those patients also tend to respond to rituximab. You can repeat rituximab, so there are a couple of patients I've got with a closely related disease called Evans syndrome, which is, in the case of these patients, is ITP with hemolytic anemia. And I've got them on a pattern of, I used to do blood tests to monitor the B cell levels, but now I just treat them every 2 years because for about 6 years that was the pattern, so I figured we may as well just treat every 2 years. The thing that really I think needs to be considered if your TPORA stops working is what's called combination therapy. So I think in the past, and clinical trials are very much sort of almost encourage this, that it's one treatment after another, lines of therapy. It's like you try something, it doesn't work, you move on to the next. But what we find in many medical conditions is actually combination therapy is better than using a single drug at a time. So you can often get away with lower doses of both drugs in the combination than you would if you're using individual drugs. So a combination of TPORAs and immunosuppression can often be very useful. And that's probably because most people have a combination of reasons for ITP. You know, they have a combination of a bit of underproduction and a bit of increased destruction. So some people are at one end of the spectrum or the other, but most people are somewhere in between in terms of destruction and decreased production. So combination therapy, and I'll just go and run through now a few of the combinations we can use. So mycophenolate, it's a drug, an immunosuppressive drug. It's used in organ transplant, but also can be used in ITP. We certainly use a lot lower dose in ITP than if you've had, say, a liver, kidney, heart transplant or whatever. It's a tablet twice daily. It reduces the population of both B and T lymphocytes, those cells that really are the sort of drivers of the immune system. Most common side effect is diarrhea. It can actually cause a disorder called colitis, which is an inflammation of the colon in extreme forms of diarrhea. And the other thing with mycophenolate, and this is really important because a lot of people with ITP, young women, is absolutely needs to be avoided in pregnancy. It has an extremely high risk of causing fetal abnormalities if a young woman gets pregnant on mycophenolate in the early weeks of pregnancy. And as Chiwi mentioned, it was used in the FLIGHT study where it was combined with steroids in newly diagnosed ITP and decreased the progression of people with newly diagnosed ITP to chronic ITP. Steroids, everyone hates steroids, but gee, they do often work well in ITP. Prednisolone is the most commonly used. Side effects, I'm sure most people in this room are very familiar with. Its long-term use is preferably avoided, and the lowest dose possible is avoided. But what you can find is prednisolone doses, even down to 1 milligram a day, can really transform someone who's stopped responding to one of the TPORAs into a responder. And honestly, doses this low usually, they do not have the side effects that the higher doses, milligram per kilogram doses use. I use steroids, but a low dose. Even people with relapsed ITP, I don't go put them back on 1 milligram per kilogram. I tend to put people on a maximum of 25 milligrams, and the response is often just as quick as the much higher doses with less side effects. So everyone hates steroids, but they can transform treatment failure into success. Sirolimus, its other name is rapamycin. It was discovered in Rapa Nui, which is Easter Island. So it's another immunosuppressive drug. Its major side effect is pneumonitis. It's not that common. Again, we use lower doses in ITP than in transplants. It's used once daily. And it's a darling of the anti-aging community. So there's this sort of weird group of people who do all sorts of things to live to be 1,000. And one of the things that they like to swallow is sirolimus. And it's supposed to be, it's one of these, if you Google sirolimus, it'll be something that, comes up as an anti-aging drug. Other drugs like vitamin B3, there are people that take cocktails of these things because they want to live forever. I just think I'll be bored by the time I get to about 100 and probably won't want to live much past that. But if you do, sirolimus might be the drug for you. The other thing always to remember is clinical trials. So most of the ITP doctors in the room, if you're interested in ITP, you tend to run clinical trials. So I've been running clinical trials on ITP for the last 20 odd years. And the advantage of clinical trials is it allows access to drugs that wouldn't otherwise be available. So there are different phases of clinical trials. Really quickly, a phase 1 trial is the earliest phase. So it's earliest in humans. So usually these drugs are trialed in animals, first of all, to make sure that they're safe. And then phase 1 is really a safety trial. So this is often in people who are desperately ill with a particular disease, or actually in normal volunteers, just to make sure there isn't any toxicity. Phase 2 is to make sure the drug works, and it's usually a dose finding. So you'll often find in a phase 2 trial, people go on sequentially higher doses. I actually like phase 2 trials because it means everyone on the trial gets drug. Whereas the next phase, the phase 3, which is kind of the later stage, actually there's usually what's called a placebo or standard of care arm. Well, there is always. So it's often a 2 to 3. Two people get drug, one gets placebo or standard of care. But, and people do go on these trials, and they should go on these trials, but, there is a chance you'll get this, you won't get the new drug, you'll get the existing therapy or the inactive therapy, the placebo. If you do go on a phase 2 or 3 trial in Australia, pretty much the requirement of the ethics committees is that you will have continued supply of drug once you come off trial until the drug is available on PBS. So that is, if the drug works for you, usually you can carry on with it afterwards. So that's good. So clinical trials, really at any stage of ITP are worth considering because they do offer, new treatments, that wouldn't otherwise be available. And most of us who treat ITP have a really good look at these drugs. We don't just randomly pick things. We look at things where there's good evidence or good theoretical basis as to why these treatments we think would work. So just on the horizon then, and these are all drugs that have recently been in clinical trials in Australia. So there are some drugs that that have really been on trials, have been shown to be successful. So rilzabrutinib there was I think 3 or 4 of us in the room did the rilzabrutinib trial. It was a drug that was reasonably, was very well tolerated and certainly was helpful in quite a number of patients with ITP. Fostamatinib, probably not quite as useful in terms of how many people benefited from it, but again, these drugs were used, some of them were used in combination with other drugs, existing drugs, sometimes they're used by themselves. But again, I'm suspecting that the best use of most of these drugs will be in combinations rather than as single agents. Fostamatinib, Tavalis is the name of fostamatinib. It is registered in Europe and in America, but it's not registered in Australia, and the company that makes it doesn't have any plans to bring it here. It was only effective in a sort of quite a small minority of patients. I don't think it's the biggest loss, but it would be useful to have it in some situations. And then there is a couple of unpronounceables, efgartigimod and rozanolixizumab, which are drugs that they're sort of alternatives to IVIG, really, that are given much less frequently than IVIG. And, certainly may be of benefit in some people. And again, I think they will be heading towards registration and availability. The really good thing about ITP is a great trial for any autoimmune study. So it's certainly not the most common autoimmune disease, but other autoimmune diseases, often to see an effect, you've got to treat the patient for a very long time. You've got to judge like kidney function, organ function. ITP is simple. You just look at a platelet count in terms of response to treatment. So it's really easy to know whether a drug's working, whereas a lot of other diseases, let's say it just takes longer, it's more complicated. So we do get to see a lot of these drugs that are good in autoimmune diseases fairly early on in ITP. So, that's been one thing that's been, quite interesting. So the other thing on the horizon, as I say, is combination therapy for newly treated ITP. And I think that's going to be the real game changer in ITP in the future, is just preventing people with newly diagnosed ITP going on to chronic ITP. But again, that needs to be more fully evaluated in clinical trials. So I think that sums up, that sort of concludes my talk. So I'm happy to take any questions, or we can...
Now, with all these other
ITP.
How does that work with everything else you take?
Yeah. Look, I mean, the thing is, as I said, most drugs, the TPORAs don't have that many interactions with the specific issue of, really of L-trombopag and the iron, magnesium, zinc things. But look, you really need to look at the specific drugs you're taking, because some drugs absolutely wouldn't have any interference with ITP treatments, and some might. So, in general, the more drugs you're on, the more likely you are to have interactions between drugs, side effects, but you really have to look at the specific sort of recipe. One of the things I love doing is you see a new patient, and I love just saying, why are you on this? Why are you on this? And just stopping a whole load of stuff. Because people are on drugs because they once had this, that, or the other, and then it just gets continued, or some other drug gets added, another one does get stopped, and often, I think very often people just get on this cocktail of drugs, and I guess it's really down to your GP to go through everything and stop things. But the thing is, I think the GPs are very kind of a bit wary. If something's been started by a specialist, the GP will be very cautious about stopping it. And the problem with the specialists is you've got one looking after your heart, one looking after your kidneys, one looking after your platelets, one looking after your brain. And they will look up, people look after their own area and add more and more into this list. And no one actually goes through and looks at the whole list and says, what are we doing here? So in answer to your question, I don't know. But you'd need to go with a specific list and, just see what can be stopped, what might be undoing the benefits of another drug. It's an important question because, people come in on 20 different drugs and you just think this cannot be good for you.